Okay, welcome back everyone to our last voiceover PowerPoint for Chapter 15, Cardiovascular System. In the last PowerPoint, we talked about blood pressure and described how to take that with a sphygmomanometer. We want to continue by talking about different factors that influence arterial blood pressure. Now, remember, arterial is referring to blood that is being ejected basically away from the heart, and specifically this is referring to left ventricular arterial pressure, like you would take blood pressure of somebody's brachial artery, as we discussed in the previous voiceover. So this is left ventricular arterial pressure that we're talking about here. I guess technically you could relate it to other pressures from the heart, but typically this is what we're referring to. So obviously one important obvious factor that impacts blood pressure is how the heart is functioning. And so we need to just define a couple terms here, one of which is heart rate. That's nothing more than the number of beats per minute, which for the average adult is probably somewhere between 60 and 90. It's quite a range. And then we have another term that we're describing here in this number one, which is stroke volume. Both of these, and we'll define that in just a moment, both of these factors, heart rate and stroke volume, are going to impact the cardiac output. And again, let's remember we're talking left ventricle blood output here. So here's the definition of those two variables. As I mentioned a moment ago, heart rate is simply the number of beats per minute, and I give you an average there of 72, which I think is pretty accurate. Stroke volume is defined as the amount of blood that's being ejected from either ventricle. Now, I mentioned a moment ago, typically we're measuring left ventricular pressures, but it turns out that if you could somehow measure the blood that's being exerted out of either ventricle, it's approximately 70 mils. And so if we multiply them together, heart rate times stroke volume is going to give us our cardiac output. And if we use those two values, 72 beats a minute and approximately 70 mils of blood ejected out of the left ventricle and right, with each heartbeat, approximately 5 liters of blood per minute that is being ejected from the heart, either right or left ventricle. So 5,040 mils is 5.04 liters. Remember, there's 1,000 milliliters in a liter. Now, that number, 5 liters, may sound familiar to you because that's approximately how much blood you have in your body. Yeah. So what that's in essence saying is that every minute, given those numbers we're using, in every minute your heart is basically recirculating the entire blood volume, your entire blood volume. That's kind of interesting. So if we were to increase the heart rate or increase the stroke volume, we're going to increase the cardiac output. And if we increase the cardiac output, that's going to cause a resulting rise in blood pressure. So I think that intuitively should make sense to you. Increase HR, increase stroke volume, increase CO, that'll increase BP, blood pressure. Factor that influences pressure, and that's the amount of blood in your body. As we mentioned just a second ago, you have approximately 5 liters of blood. When we take into account the plasma and the formed elements, what would happen if we increased or decreased blood volume? Let's say you lost blood, lost a lot of blood. What would that do to your blood pressure potentially? Well, it could drop it so low that you could go into what's referred to as shock, and that's not good. You could die from that. Subsequently, if you were to also increase blood volume, put more water, if you will, maybe, into the plasma, it's going to increase the blood volume. That's going to cause an increase in blood. Okay. So if we were to increase blood volume, that would cause a rise in blood pressure. If we were to decrease blood volume, that would cause a drop in blood pressure. So there's our second set of factors that influence blood pressure. Here's a third one, a little more difficult to kind of understand, called peripheral resistance. Peripheral resistance, or PR. This gets at the friction that forms between the formed elements and the wall of the blood vessel that we're talking about. So let's pick an artery, for example, or a vein. Doesn't make any difference. You know that around the very circumference of a blood vessel, around the lumen, is simple squamous cells, right? That's that endothelium. And so if you can picture blood passing through a blood vessel, let's cross-section that blood vessel and think of blood passing through it. The blood in the very center of the lumen is going to be traveling the fastest, and the blood cells that are bumping up against the smooth endothelium are going to be traveling the slowest, because as they bump up against that simple squamous, that endothelium, there's a friction that forms. And that particular friction is called the peripheral resistance. So what would happen to peripheral resistance if, let's say, we contracted the smooth muscle in the tunica media of that artery? Well, the lumen would get smaller, wouldn't it? And if the lumen gets smaller, that would cause the peripheral resistance to go up. And if the PR goes up to blood pressure, well, that's going to cause a rise in blood pressure. It's sort of like when you go to wash your car, let's say, and you have an open hose that you've turned the faucet on, and so you got water coming out the hose. If you were to plug the end of the hose with your thumb, like we've always done to get the water to spray further, that's going to cause the water to come out with more force, won't it? Well, it's the same sort of idea here. If you contract the smooth muscle, if you stimulate the smooth muscle to contract, you get constriction of the lumen, you have more force of the blood going through that blood vessel. Likewise, what would happen to the PR if you relax the smooth muscle? Well, that would decrease, wouldn't it? And if the PR decreases, what would that do to BP? That would decrease as well. And our last factor, we're going to talk about blood viscosity. Viscosity is a term that describes the thickness of a liquid. Can you think of any liquids that are viscous? Well, honey is viscous, right? It's thick. 10W40 oil that you might use in your lawnmower or your car has a thickness to it. You've all seen that before. Well, your blood likewise has a thickness. It has a viscosity. And that viscosity is due primarily to the formed elements. Now remember, blood plasma is 92% water. But there are some dissolved plasma proteins in that plasma, and you of course also have the formed elements. You have red cells, lots of red cells, and some white cells and some platelets. So it's primarily the cells that contribute to the thickness of your blood. And it's not watery. It does have a thickness to it. It has a viscosity higher than water. If we were to increase, for example, the RBC count, increase the formed elements, the numbers of red cells, for example, or white cells, for example, too, that would increase the blood viscosity, the thickness. And if we increase viscosity, we increase blood pressure. So as factors, be it blood volume, heart rate, stroke volume, cardiac output, peripheral resistance, or blood viscosity, if any of those increases, we see the blood pressure go up. So we talk about a direct relationship, right? Unlike, say, hydrogen ion and pH, that's an inverse relationship. These are direct relationships. If any of those factors go up, the blood pressure goes up. If any of those factors decrease, blood pressure decreases. Here's another mathematical equation that you should be aware of. BP, blood pressure, as we said a few moments ago, is impacted by different heart actions like stroke volume and heart rate. In fact, that is cardiac output, isn't it? So there's CO. We're also incorporating into this mathematical equation PR, which is peripheral resistance. So we can now think about blood pressure being impacted by heart rate, stroke volume, and peripheral resistance. If we multiply the CO by the PR, that gives us the peripheral or the blood pressure. If we have a rise in blood pressure, let's say elevated beyond normal, how could we bring that blood pressure down? Well, we could decrease either of those two factors, CO or PR, right? How could we decrease cardiac output? Well, because cardiac output equals heart rate times stroke volume, we could lower cardiac output by lowering either or both heart rate and stroke volume, right? We could also decrease peripheral resistance as well. That would decrease blood pressure, wouldn't it? So your body has a way of maintaining adequate blood pressure. If it goes up too high, let's bring it down. If it goes too low, let's bring it up. It's classic negative feedback, homeostasis here as it relates to blood pressure. So let's talk a little. Helps to maintain that 120/80 that we talked about in the previous voiceover. Here are two schematics. The one there on the left was from an older edition of the textbook, and the one on the right is the one that you have in your book on 589. They're both the same thing. Nothing new here. They're just two different ways of kind of viewing the process. So let's take a look at the one here on the right, which is in your book. Here's our normal blood pressure, 120/80. If it gets too high, how can we bring it down? Well, we're going to be making use of receptors, control center, and effectors, right? So in your aortic arch, as we described in the previous voiceover, and in your carotid arteries, you have baroreceptors. These are pressure receptors. These are stretch receptors. And if your heart is racing very, very quickly, as your heart rate is going up and your cardiac output is going up, that's going to cause these baroreceptors to become stimulated. And they're going to send sensory information to the medulla, right, where the cardiac center is located. Also where the vasomotor center is. We talked about that in the previous voiceover. So if you've forgotten what that is, go back and review that. So in an effort to bring blood pressure down, what can the heart do? Well, the brain will send motor signals to the heart, and we can cause increased parasympathetic impulses, right? That's going to decrease heart rate, that's going to decrease stroke volume, that's going to decrease cardiac output, that's going to decrease the blood pressure and bring it down to where we want to go. The vasomotor center is going to impact the smooth muscle of blood vessels. Remember we said vasomotor center does not impact heart. Cardiac center does not impact blood vessels. The vasomotor center does, which lies right next to the cardiac center in the medulla. So in this case, the vasomotor center is going to send less sympathetic impulses to the smooth muscle. That's going to result in less contraction of the smooth muscle. In other words, the smooth muscle will relax. If you relax the smooth muscle, make the lumen bigger, what does that do to the PR? Well, that reduces it. And if the PR goes down, the blood pressure will decrease. So those are some factors that help to take an elevated blood pressure and bring it down to normal. In the lower half of the diagram, we have just the opposite. If the blood pressure falls too low, how can we bring it up? Well, I think you ought to be able to take a look at this, given what we've just discussed, and determine how that happens. But make sure you take a look at this diagram. This is, again, classic homeostasis as it relates to blood pressure. This would be an excellent question, essay question for the test. So know this. Know this. Okay, we're going to go back and talk a little bit about stroke volume and heart rate, which you remember a few moments ago determined cardiac output, which in turn impacted blood pressure. So what are some factors that impact the amount of blood being ejected from the heart, as well as what are some factors that influence heart rate? Because those factors will in turn influence blood pressure, won't they? First of the three factors we'll talk about are mechanical factors. And this is an interesting phenomenon that was elucidated back in the early 1900s, I think, by two scientists who independently came up with this finding. One guy named Frank, one guy named Starling, and they both are now credited with what's called the Frank-Starling law of the heart. And it's kind of a complicated thing to describe, but I'm going to just give you the 8th grade version, if you will. And that simply describes the fact that if you take cardiac muscle tissue and you stretch it to a particular length, you can't do this indefinitely, but there is a limit to which you can do this. But if you take cardiac muscle, say in the wall of the left ventricle, let's pretend, and you stretch that, the result will be that the heart muscle, the cardiac muscle tissue will contract with more force. Another way of saying that is if you don't stretch the heart muscle fibers as much, it won't contract with as much force. So this is basically helping to ensure that when you look at the amount of blood that comes into the, let's say the right and left ventricles from the atria, that the same amount of blood is being ejected when those ventricles contract. So when you're exercising, running a marathon, let's say, you know that your heart rate is increased. Well, your blood pressure has also probably gone up too, right? So as you're exercising, you're taking more blood and putting it into the ventricles to ensure that they contract with more force to deliver that blood to your muscles that need that oxygen to keep going aerobically, right? Got to deliver that O2, pick up that CO2. And so it makes perfect sense. Just think about it. And that's kind of what this mechanical factor Frank-Starling law talks about. A second factor is one we've already discussed, actually, and that revolves around neural factors. And I'll have you go back and remember the stretch receptors that we just talked about a few moments ago in both the aortic arch and in the carotid sinuses that are monitoring arterial blood pressure. And again, this is the same stuff we just talked about a few moments ago. If the cardiac output, let's say, is elevated, if the blood pressure is higher, how can we bring it down? Well, as we said, baroreceptors in these two parts of the heart will be stimulated. They'll send impulses to the cardiac center. More parasympathetic impulses will be sent, motor impulses sent to the SA node. We're putting the brakes on the heart. The heart rate will slow. If the heart rate slows, we know the blood pressure will decrease. Remember, this is a direct relationship. Conversely, if the cardiac output is, let's say, decreased and the blood pressure is lower than it should be, then we're going to send that sensory information via the baroreceptors to the cardiac center, and we're not going to put the brakes on the heart. We want to accelerate the heart. We want to bring that heart rate up. So therefore, the accelerator nerves will release that norepinephrine at the AV node, SA node, and also within the myocardial tissue of the ventricles. That's going to cause blood pressure to go up. So again, take some time to review that. This speaks to the vasomotor center, remember, which does not impact the heart. It impacts the smooth muscle of the blood vessels. So check that out and review that. There's also a video that I showed you in the previous voiceover that I'm not going to play it, but I want you to watch that video. It's an excellent summary now. You should be able to watch this and fully understand what this is talking about. Our third and last factor are chemical factors. And we've listed 3 important blood chemicals: CO2 in the blood oxygen levels, and blood pH. Notice that all of these 3 chemicals are influencing the peripheral resistance. Remember, this is the friction that forms between the blood and the walls of the blood vessel, the inner lining there, the endothelium. Now, this is specifically talking about how these 3 chemicals are going to impact peripheral resistance by influencing the smooth muscle, specifically in the walls of arterioles and precapillary sphincters. We talked about these precapillary sphincters in the previous voiceover. These were individual smooth muscle fibers that wrapped around the arterioles just before you got to the capillary. So that's the term pre-capillary, before capillary. So if you were to contract the smooth muscle in the wall of the arteriole, or contract the smooth muscle within those precapillary sphincters, that's going to reduce the flow of blood, won't it? It's also going to result in increased peripheral resistance because you are diminishing the lumen size. A little bit about some of these chemoreceptors. Okay, now remember, these are chemoreceptors. They're monitoring blood chemistry, specifically CO2, O2, and hydrogen ion concentration. Earlier, we talked about baroreceptors in the carotid sinus and in the aorta. Well, it turns out that in addition to these baroreceptors, there are also chemoreceptors in the same regions of the heart. They are monitoring, in this case, blood chemistry. So when these chemoreceptors that are monitoring this arterial blood being ejected from the left ventricle after having come from the lungs, when they detect an increase in blood CO2 or a drop in blood oxygen or a drop in blood pH, they will in turn send sensory impulses to the vasomotor center now of the medulla, not the cardiac center, the vasomotor center, because this center, remember, is going to impact the smooth muscle of these arterioles and these precapillary sphincters. How will that impact those structures? Well, as it says here, when you have a rise in blood CO2 or a drop in blood oxygen or a drop in blood pH, that is going to result in the vasomotor center sending less sympathetic impulses to the arterioles and the precapillary sphincters. Remember, the sympathetic stimulation is going to stimulate the smooth muscle in the blood vessel to contract, I should say, resulting in constriction. So if you decrease the sympathetic stimulation, okay, if you leave up on the accelerator, if you will, that's going to cause the smooth muscle to relax. And in turn, we use the term vasodilation to describe that. The smooth muscle will relax, the lumen will get bigger. When the lumen gets bigger, that permits more blood flow through those blood vessels. So again, just think about it. If you're running that marathon and you want to deliver more blood to your muscle, to the capillaries that feed your skeletal muscle as you run that race, one way to get more blood there, in addition to increasing heart rate, which we know we talked about a few moments ago, would be to utilize again the vasomotor center to decrease the stimulation of the smooth muscle. In other words, less contraction, more relaxation, more vasodilation, more blood flow to the tissues. We looked at this diagram in the previous voiceover, and so you should be familiar with this. This again is monitoring blood pressure as we move from the aorta, where as it's being ejected out of the left ventricle, remember this is ventricular pressure, left ventricular pressure. We have a blood pressure typically of 120/80. That's what we would measure, for example, in our brachial artery and many of the arteries that branch off the aorta. And then as we trace the flow of blood from the large arteries into smaller arterioles and eventually into capillaries, we see a really substantial drop, don't we, in blood pressure, because we're getting further from the heart. By the time you get to the capillaries, as I said in the previous voiceover, that blood is traveling very slowly, and the red blood cells are moving through these tiny blood vessels in single file, aren't they, to optimize diffusion of gases and nutrients and waste products. Once we get out of the capillary bed, after we've done our diffusion of CO2 and oxygen and nutrients for waste products, we've got to get that blood then back to the heart somehow. We've got to take it eventually into the venules, and then the small veins and the large veins, and ultimately the superior and inferior vena cava. And then we will, of course, get back to the right half of the heart, and we can pump it to the lungs, bring that blood back from the lungs to the left side of the heart, and start all over again. So we want to talk next about venous blood flow. Okay, how does the blood get from here, from the capillaries, back to the vena cava? How does that happen? The heart is not contributing to this. There are other One important force that helps to push blood through veins is good old skeletal muscle contraction. So here we're looking at a vein, and how do I know this is a vein here in blue? A dead giveaway, which you all know, are these things, right? The valves. And we see that the valves in this case are closed. And so how is that blood getting forced eventually through those blood vessels? Well, we have to look at skeletal muscle that is surrounding most of our veins and arteries for that matter as well. But we're talking here about venous blood flow. So when the skeletal muscle is relaxed, these valves snap shut. When the skeletal muscle contracts, it pushes in, doesn't it, on the lumen here of the blood vessel. See how it's a lot narrower here as a result of the contraction of the skeletal muscle? And that squeezing, if you will, due to the contraction of the muscle, is going to help push that blood upward in this particular example. The valves here will open. The valves below the contracted region, they don't open, they stay closed. Just think about pressure differences. Again, we said what determines valve opening or closing is due to pressure changes on either side of the valve. So in this case, the pressure on this side exceeds the pressure on this side. Because of the contraction of the skeletal muscle, the valve opens up. What's going to likely happen right afterwards? Well, we're going to get a relaxed situation, and this valve will snap shut. We might have contraction down here and cause blood that was down here now to come up toward the heart. So normal relaxation and contraction, alternating contraction and relaxation of skeletal muscle is a really important force that assists in getting that blood from the small venules through the large veins and then eventually to the venous. Here's our second of the three factors that impact venous blood flow, and it's respiration. Who would ever think that just normal breathing impacts blood flow in veins? Well, it does. I'm not going to review respiration. We talked about that in the respiratory chapter 19. But as you inhale and exhale, you're causing blood within abdominal veins and thoracic veins to get pushed around, if you will, to get moved within those blood vessels. Just the normal movement of the diaphragm. As you inhale, the diaphragm contracts, remember, and that's what's being shown here on the left-hand side of this diagram. Inhalation causes the diaphragm to go from a dome-shaped morphology to a more flattened orientation. That is causing blood within the thoracic veins and abdominal pelvic veins to get squeezed. When you exhale air, the diaphragm, as you can see on the right-hand side here, goes back to a more dome-shaped orientation. The muscles here, intercostal muscles, are also relaxing, of course, and we have this elastic recoil that we described in the respiratory chapter, all of which is going to, again, allow blood to sort of pool in those blood vessels. And then when you take another inhalation, the blood gets squeezed. So the blood gets pushed through, basically, as a result of your inhaling and exhaling, inhaling and exhaling. It's a really important mechanism. The last process is getting back to this idea that if you look at a vein or even a small venule, you have a tunica media layer with smooth muscle in it. And as we said a little bit earlier, if that smooth muscle contracts, if it's stimulated to contract, right, that's going to cause an increase in peripheral resistance, which will in turn cause an increase in blood pressure. So that's what this third factor is talking about. If your blood pressure gets too low, we will have sympathetic impulses emanate from the vasomotor center, and that will cause the smooth muscle in the wall to contract. The lumen will get smaller. If the lumen gets smaller, the friction between the blood and the wall of the endothelium goes up, which is PR, and if PR goes up, as we know, direct relationship, BP goes up. This is called venoconstriction. Veno referring to vein, veno. Now keep in mind, as we said in the last part of the previous voiceover, most of your blood, 70% of your blood volume, is found in veins, large and small veins. So as I said at that time, if you hemorrhage, if you lose blood, the first thing that's going to happen is you're going to try to tap into that blood reservoir to get adequate blood flow through the body. And the way that happens is through this venoconstriction process. It's diverting that blood out of veins and venules and trying to get it into the circulation where it's needed. Now again, you can't be hemorrhaging indefinitely, otherwise you go into shock and you can die. So this has limitations, but this is one way to maintain adequate blood flow, to maintain adequate blood pressure if you do deal with a hemorrhage situation. This venoconstriction is really important. Okay, as you then approach sections 15.5 and 15.6 and 15.7, I want to just make a few comments. 15.5 is very short. I do want you to read that over, and I want you to review the pulmonary circuit and the systemic circuit. That's described there on page 592 through 593. And there's also a figure, 15.39, which I mentioned here on the slide, that summarizes the two. We've talked about this before. There's nothing new. Take a look at that figure 15.39 and be familiar, intimately familiar with all of those blood vessels and the blood flow. Know what pulmonary and systemic circuits involve. When you get to section 15.6 and 15.7, we're not going to talk about that in lecture. This is going to relate specifically to lab exercise 40, which you're going to be doing next week. Our last lab, one of those exercises is exercise 40. And so as you look at various major arteries and veins in the body, as you label those in the lab exercise, you should have your textbook handy so you can reference section 15.6 for major arteries and section 15.7 for major veins. Okay, so I'm not going to hold you responsible for those sections for the 4th lecture exam, but some of these you're going to have to know for the lab practical, specifically lab exercise 40. So have your textbook at hand when you do exercise 40 in the lab. The last thing I'll leave you with is an article that is in Blackboard that I think you'll find interesting. So make sure you take a look at that, print it off, read it. You could see a question on the exam on that article. This then wraps up our last voiceover for chapter 15, which only leaves lymphatic system and immunity left, and then we are done. So hang in there, and we'll see you soon.